sessions. Would request all of you to please be a little patient. We're going to start very shortly. Good morning, everyone. Let me take this opportunity to welcome you to the National Summit, Preserve the Uterus, a joint initiative of the global pharmaceutical giant Bayer and Integrated Health and Wellbeing IHW Council in collaboration with the Federation of Obstetrics and Gynecological Societies of India, FOGSI. We at IHW Council have been relentlessly working on creating awareness around health and well-being. The guiding philosophy behind IHW Council is that health should be a priority for all, without which it is not possible to realize the potential of all human needs. We firmly believe that good health of its women is important in raising healthy and prosperous societies and nations. Bayer has been a pioneer in women's health for decades and has not only been providing innovative and pioneering solutions for women's health, but it is also actively involved in creating awareness around critical health issues faced by women. The Save the Uterus campaign was launched in April 2022 this year to raise awareness amongst women as well as healthcare practitioners about the uterus, a vital reproductive organ, and the negative impact that an untimely or unjustified hysterectomy can have on the physical and mental well-being of women. According to the 4th National Family Health Survey 2015-16, out of the 700,000 women between the ages of 15 and 49 years, 22,000 had undergone a hysterectomy. Hysterectomy is the most commonly performed surgery amongst women globally after cesarean section and has serious implications on the physical and mental well-being of women. The number of cases in India is higher in rural India, where women are expected to do physical work and are not aware about the impact of such surgeries on their physical and mental well-being. Preserve the Uterus campaign was launched as a nationwide campaign in 2022, April, by Bayer in collaboration with Federation of Obstetrics and Gynecological Societies of India, FOGSI, and IHW Council to empower women with the right awareness, thus enabling them to make empowered choices. This initiative also focuses on capacity building of health practitioners and understanding policy perspectives in states, strengthening health systems to tackle the issues, and most importantly, the use of media to create awareness on the impact of hysterectomies. The need of the hour is to come forward and support to clear misconceptions and myths around reproductive health of women, especially fibroids, endometrial malignancy, heavy menstrual bleeding, and anemia. In the last couple of months, a number of state-level summits were initiated under this campaign, where experts from Andhra Pradesh, Maharashtra, Telangana, Uttar Pradesh, and Gujarat came together for discussions on the current scenario of hysterectomies in their respective states and the way forward to curb unethical operations. The National Summit aims to keep the conversation around women's health going and remove the stigma and taboo normally associated with these issues. It is imperative that we empower our women so that they are aware of their health and bodies and are able to make informed choices. Without further ado, let's start the session. Hysterectomies in India, Problems, Policies, and Perspectives. Please join me in welcoming on stage our esteemed experts for this session. Please welcome on stage Dr. Amita Bali Vohra, DDG, Government of India. Please put your hands together and welcome on stage Dr. Amita Bali Vohra. Please welcome Dr. A.M. Rathore, Director, Professor and HOD, Obstetrics and Gynecology, Maulana Azad Medical College, New Delhi. Please welcome Dr. Sunita Mittal, Director and Head, Obstetrics and Gynecology, Fortis Memorial Research Institute, Gurugram. Please welcome Mr. Manoj Saxena, Managing Director, Bayer Zydus and South Asia Head, Pharma. And the session will be moderated by Mr. Kamal Narayan, CEO, Integrated Health and Wellbeing Council. A round of applause for all our speakers on stage. We are eager to hear their thoughts on the practice of hysterectomies in our country and what is the way forward. I'll hand it over to Kamal to take this discussion forward.
Thank you so much, Anisha. So good morning, everyone. Sorry for being a little late in starting this session, but I'm sure that the kind of knowledge all of you and the understanding of this issue you are going to get in the next 1 hour of this session and also during the day will kind of compensate for it. So welcome our esteemed guests and experts today on this session. As Anisa, highlighted that, and it's just, kind of for many of our audience who, kind of do not come from the medical background. We have journalists also in the hall. It may be a, kind of an interesting fact that hysterectomy surgeries are the second, largest number of surgeries happening among women after cesarean surgeries. Now, to understand it a little bit more, and as the session goes, kind of problem, policies, and also solutions. Let me first, kind of invite Dr. Sunita Mittal to give up, a little bit of understanding about what are hysterectomies, why are they needed, and what kind of make them the second largest number of surgeries happening globally, and also in a large number of cases in India as well. Dr. Mittal.
Thank you, Mr. Kamal Narayan. Good morning to everybody. May I first request, please, these flashlights to be switched off, because I can't see any of you because of these flashlights. Yes, thank you. All, we don't need them. Okay. As rightly pointed out, hysterectomy is the second commonest surgery being performed globally, not just in India, it is globally. Yes, there are conditions. It is basically removal of uterus. For non-medical, it is a removal of uterus from a woman's body. And many people go with the thinking that function of uterus is only to reproduce. So if she has finished her childbearing, and if there is a disease with the uterus, it is better to get rid of it rather than continue to suffer from the disease. I think during the panel, we will discuss that even if it is a diseased uterus, there are many other alternatives rather than just chopping off the uterus, which becomes very radical. But why do we need to remove it? There are certain cases where removal of uterus will be inevitable. If there is a uterine cancer, if there is an ovarian cancer, probably still you would like to remove the uterus. Barring these, majority of the benign conditions which call for removal or for which removal is being done. And in fact, in many cases, we come across where removal is being done on some flimsy ground. There is not even an indication to remove it. Little discharge and say remove uterus. But otherwise, yes, we do need to remove it sometimes when there are multiple large fibroids, when the uterus is causing so much of bleeding that woman is getting anemic, her life is becoming miserable, and somebody thinks, okay, let's remove it. The alternatives will be discussed for bleeding, but still, many people think if she's bleeding too much, becoming sick, getting so much of weakness because of low hemoglobin, why not remove it? So that is second common indication for removal of uterus. And third is, as age advances, the uterus support lacks sometimes. So the uterus starts coming down. We call this medical condition as prolapse of the uterus. And sometimes it becomes difficult for the woman to be very functional with prolapse uterus. So there also one considers removal of uterus. So these are three commonest indications where it may be indicated.
Thank you so much, Dr. Mittal. So I think one important point which you have highlighted is that removal of uterus can be inevitable in certain conditions, and maybe in certain age also, because many of those conditions are age related as well. But at the same time, you have also highlighted that there are many other conditions which are easily, kind of medically manageable, or manageable through non-surgical procedures as well. Let me go to Dr. Amita Bali. And before I ask the question, Dr. Bali, let me, kind of put forward a case study which I, might have, I got to kind of experience very closely. A woman in his, kind of early 40s, or maybe at, the age of 40, in city like Lucknow, faces or experiences some heavy menstrual bleeding, goes to a big corporate hospital in the city, which is also the capital city of one of the largest and most populous state of our country, and was, after diagnosis, told to remove the uterus. Obviously, sometime it becomes up, to go for any surgery, people become little panicky, and they, kind of consulted multiple doctors. The woman being my relative, she also consulted me, though I'm not doctor. But she got to know that we are doing something related to uterus, and when was told that uterus need to be removed, she thought she should check with me. I also, connected with some, kind of veteran doctors like Dr. Mittal, to kind of understand that. And then we realized that that condition could be easily, kind of managed through medications, or, other medically, medical kind of, regimen. In such case, now this is something maybe, kind of closer to me, to this, that becomes shocking for me. But at the same time, this is something many of us, and a lot of, even you would be seeing every day. It is nothing, kind of new to see a case where uterus removal is being prescribed. But when we see it that it was not needed apparently, but the doctor, I'm sure with the best of, kind of good judgment, had prescribed that, while the other doctors felt the other way. We consider that way. So, Dr. Pali, is there any specific guideline, any specific protocol, which, kind of is being followed by all doctors and professionals to reach to this conclusion that uterus need to be removed, or it can be managed through some other alternative way?
First of all, on behalf of the Director General of Health Services, I wish you all a very good morning. And I thank the Integrated Health and Wellbeing Council and BRAE for organizing this summit today. Thank you for inviting me here. I will start with some statistics which I have found. It is seen that, as ma'am said, hysterectomy is the second most common non-obstetric surgery which is being done in the Indian as well as the international women population. The average prevalence in the age group of 15 to 49 in India is 3.3%. And in cities like Delhi, it is 1.7%, Meghalaya 0.7%, and Chandigarh 0.9%. And on the other end of the spectrum, we have Bihar with 6%, Andhra Pradesh with 8.7%, and Telangana with 8.2%. And it is also noted that in women who have received no schooling, the incidence is 7.1%, whereas those with 12 years of schooling, it is 0.9%. So it is very amply clear that as long as the women don't get the informed advice and the proper information regarding how to go for a hysterectomy and whether to take the correct decision, the incidence remains high. And similarly, in the age group of 40 to 49 years, the national average is 9.7. Andhra Pradesh has 23%, Telangana has 20%. So, as the indications which ma'am has said, fibroids, dysfunctional uterine bleeding, PID, prolapse, malignancy and pre-malignancy, these certainly are the indications, but there are so many medical as well as less invasive techniques which can be thought of before going directly into hysterectomy. And the reason for concern is that more and more younger women, sometimes as young as 28 years of age, are going for hysterectomy because in India, the age of marriage is less and ladies generally complete their childbearing by the next 10 years. So unfortunately, women in their 20s and 30s are going in for hysterectomy. And most of these ladies are from the poor socioeconomic strata, from the rural or the suburban background. They are uneducated. And we have a suspicion that these unnecessary hysterectomies are being done for financial benefits under the insurance schemes. So as you rightly pointed out, when such a lady who has been advised hysterectomy, especially in a younger age group, comes to us, we have guidelines to guide them regarding what medical procedures could be done, what medical management can be done. And we have to take into consideration the other challenges like what kind of a postmenopausal symptoms she will go through. So these should be considered and guidelines are in place, but these have to be sent to the primary, secondary and tertiary levels all over the country and they have to be adhered to. That is very important. These guidelines may be in place and unless the awareness both in the medical professionals and in the public is not there, these guidelines will be difficult to be followed. So I think, sir, this is what should answer your question.
Thank you so much, Dr. Bali. You have, kind of put forward a lot of interesting statistics. I'll come to Dr. Mittal.
To add something in lighter vein, Dr. Amita very beautifully highlighted from state to state how the hysterectomy rate varies. There is a village in Rajasthan which is nicknamed as Uterus Free Village.
No.
So this is the state of affairs in our country. There are some villages where anybody about 20 years is minus a uterus. So we have to be very careful. That is one thing I wanted to say. And you also raised an issue of having guidelines. I want to bring forth this also, that in our country, you're talking of guidelines. We have still not managed to control quacks. Forget about the qualified people. And for that matter, hysterectomy is a domain of a gynecological surgeon. Still, more hysterectomies are being conducted by general surgeons when they're not supposed to do it. Statistics varies from state to state. I'm not going to comment on it, but if you go proportion-wise, 70 to 90% hysterectomies in some places are being conducted by general surgeons. So even if Folksy comes out with some guidelines, even if we say do this, do that, they are not going to follow whatever we say. They are qualified people, postgraduate. Forget about the quacks doing.
Thank you so much, Dr. Mittal. Important add-on, but at the same time, when guidelines, may not be the only tool or solution in such a scenario when from general surgeon to quacks to kind of non-trained people involved in doing these kind of procedures, and it happens in many parts of our country. And I'm sure in that case the awareness becomes one of the major important tool, because the patient, the women, those who are going into that surgery, then they can take a better decision when they are being prescribed. They can understand, they can try for kind of consulting a better expert on that. Let me come to Dr. Rathore. Dr. Rathore, so we saw that there is a problem, and Dr. Mittal has highlighted that the problem has different size and shapes in different states of our country. It is so at extreme level in certain cases, in like the kind of example of that Rajasthan village, or we see if in in otherwise also multiple states having a very high kind of burden of it. Uh, how do you see kind of apart from guidelines, because you are a teacher, you are teaching the upcoming gynecologists who will be kind of practicing bringing women health, a critical health intervention across the country. What is your, how do you see that they can play an important role? What kind of skilling is kind of need to be added into this system, and along with the guideline also, in how to kind of sensitize them over the period? Dr. Mittal belongs to a, as of now, to a corporate hospital, and we have also seen that when these numbers were being mentioned by Dr. Amita, that many of these cases are happening in private settings, and in private settings also comes the angle of commercial gains. Many of your students are going to practice in private setups. What kind of messaging and what kind of ethics training you believe are important to ensure that we are not kind of getting into the certain or trading the somebody's health for commercial gains, which has been seen, as mentioned by other experts also, in many of the cases where we see a higher number of hysterectomies.
First of all, thank you so much for inviting me on this program. On behalf of Association of Obstetrics and Gynecology, which is the member body of FOGSI, which is part of this collaboration, it's my great pleasure to be part of this initiative. And as Dr. Mittal rightly pointed out, society in general looks at uterus as an organ of reproduction. And it's very important to remember that uterus, apart from being an organ of reproduction, which is a very, very important function, it has a lot of long-term impact on women's physical, mental, and emotional health. It has an ovaries attached to it, which secretes the hormone, which are very important for your bone health, your cardiovascular health, and a long-term emotional health of a woman. And so just after the childbearing is completed, our thresholds for removal of a uterus should go down. The concept, which is very prevalent even in a woman who herself many times comes with a demand of an hysterectomy, it needs to be addressed in a different way. Dr. Mittal very nicely pointed out the indications for hysterectomy. We all know we have a lot of guidelines, lot of evidence-based guidelines and literature, where we try to classify into 3 groups. In one, there is hysterectomy is the treatment of choice, which is not a controversial area. Then there are certain medical conditions where hysterectomy is one of the options. Where do you have an other options? And in this particular second group, you really need an sensitization of healthcare provider as well as woman. It's the interaction between two and the judgment of a clinician as to hysterectomy is the better option vis-a-vis a non-surgical option or a uterus preserving option is an individual decision which is customized to an individual woman. Then there is a third category where hysterectomy probably medically is not indicated and which is probably the most controversial one. I remember, and Dr. Mittal will agree with me, the controversy with unindicated and untimely hysterectomy started when these hysterectomies were performed in young girls who were mentally retarded. And they were sort of taken as a solution for the parents' misery of how to take care of these girls. That time, the awareness about the other benefits of uterine preservation were not so common. So, and as a clinician, the doctors need to be sensitized about which type of an indication or an individual woman you are dealing with. So the approach of a logical use of hysterectomy as a treatment option has 2 aspects. Number 1 is sensitization of a healthcare providers regarding the benefits of uterine preservation on the long-term health of a woman. Then what are the various treatment options if hysterectomy is not to be used and a woman is symptomatic? There can be drugs or a medical treatment. Then there are devices like an intrauterine progesterone devices. Then you also have a non-surgical minimally invasive options like an uterine artery embolization. You have an high frequency ultrasound waves. And again, even a surgical but uterine preserving surgeries. So there are multiple options available to manage a particular clinical situation, which can be utilized. And second important component is your end user, that is the woman. We need to educate women also that most of the times, especially in public hospitals, a woman is referred from a faraway village. She feels, madam, ek baari mein kaam khatam kar do, main baar baar nahi aa sakti. So in such a particular situation, we need to educate her that its uterus is not only for reproduction, but your long-term health depends on this. So education and sensitization of a healthcare providers regarding non-surgical options or a uterine preserving options. Apart from knowledge, availability of all those resources to undergo those treatments, and then their skilling to utilize those options. And for women, probably awareness. And this awareness cannot come in one visit. If woman comes to me with a symptom and then I try to start telling her that you now try to conserve the uterus for her, at that point of time, that symptom is more predominant than the surgery. So this type of awareness has to come from every interaction we have with a woman, starting from young age, her pregnancy, and it has to be a long drawn process. It's not a one-step procedure that we can counsel and convince her that preservation of uterus is very important. So I think these both the prongs needs to be addressed.
Thank you so much, Dr. Rathore. You have highlighted one of the very important aspect to it, because when we are looking at hysterectomies and also their removal after especially the child-bearing responsibility of a woman is over. Just a second, ma'am. Yeah, I'll just come to you, Dr. Amita, for that. So, highlighting the aspects of that, it is not some disposable organ. It has the whole function and role in your overall well-being. And when you are removing uterus in an early age, you are also risking the women's health in multiple aspects. You talked about cardiovascular problems, you talked about early onset of osteoporosis, mental health, and so on and so forth. Now, so let me, Dr. Bali, want to add something?
As ma'am was talking about the decision making and explaining to the patient, here in India, it is more important because the decision is made by the entire family. So public awareness and public education is very important.
Yeah, so public awareness and education, because you're also highlighting that many times it is the patient or the women themselves come prepared and they are demanding for it, and there's sometimes the kind of symptoms are so strong and intense that they want to get rid of that, and they not much more concerned about what would be the consequences of removing the uterus in long term. So this requires a more of maybe kind of hand-holding and guidance from the healthcare experts, doctors or treating doctors, and at the same time it also requires a lot of awareness among the people. Let me go to Mr. Manoj, and what has been, we have been kind of witnessed new techniques or new innovations or solutions. So been taking this whole cause of public awareness, addressing such a problem, which also is quite a sensitive problem in country like ours. What has been your experience? What kind of objectives you had when you came up with this thought of initiating this initiative, which then was partnered by Foxy, by ISW Council, And how do you see the, a role of a public-private partnership in terms of, kind of making this, objective really met?
Thanks a lot, Kamal. I guess your question is long. Let me answer the first part. Why are we in this? A lot of time when a corporate comes and does this, people look at it, okay, we are going to make money. Yeah, absolutely not. The solution what we have is there in India for many, many years. It's actually under price control. It's in the National Essential Drug List. And some of you are familiar. The cost is actually less than 2 rupees a day. Yeah. For the ING-IUS. So it's an innovative product which we sell across the globe. But in India, the price points are really low. It's under price control. And that's our, partnership with the government of India when the NLEM was done for the last 6-7 years. So beyond the profitability, and gynecologist here knows Bayer more than I know Bayer. They've been associated with Bayer for many, many years. Essentially, our outlook on women's health is immense. And in every segment, whether it's contraception, whether it's endometriosis, whether it is PCOD, and also HMB, our contribution in every country and more importantly in India is to an angle to look at it what the country needs beyond just selling the drugs or selling a solution. And when we especially look at heavy menstruation bleeding, which is an indication for our solution for many, many years, we also realize our ability to drive home the message is yeah. And I'm really happy that we kicked off Preserve the Uterus mission earlier part of this year. We are extremely happy to have IHW joining. And we are, in future looking at more partners to come in because this cannot be done alone. Yeah. And what are we trying to do? This is something what Dr. Rathore also said, and I think Dr. Bali was also saying. Essentially, we are looking at doing 3 things. Yeah. The first and foremost is communication to the community so that they understand hysterectomies. A simple thing like hysterectomies is not understood. Some of them also feel that uterus can be removed and it's a good solution. So how do we communicate in language which they understand? Yeah, and you have been part of the communication exercises as well. Vernacular languages, not using just the English, but languages which a female and also the family understand. I think that was a great point. Second is, can we work with the Foxy to upskill doctors to really look at modern solutions? Because, and I think that's where it's also important that Foxy has been really a very, very good partner with us and communicating openly. These are the challenges, what can be done for the gynecologist. So really upskilling, going to those states. We started adopting 6 states in the first slide, going and upscaling clinicians and helping them and using thought leaders like all of them who are sitting here in the panel. And the third pivot, which is your question around public-private partnership, we have seen, I think in any success, when we want to impact the societies and the communities, it has to be a solution which works both in public space as well as private. We know health is managed by state in India, right? But we also know the contribution with private organizations do, whether it's medical hospital, private corporate hospitals, but also private clinics of each gynecologist. So the issue is actually in a self-pay country like ours is to understand how the government can work together, generate data. Dr. Bali said, gave a lot of data which is startling, right? 22%. A village, for example, what Dr. Mittal said in Rajasthan is uterus free. We do not have data at a district level. We do not have data at a medical college level. And I think public-private partnership to do pilots, what will work in these communities, how will the modern solution which is working in across the globe can be brought into India? How do we make guidelines or look at the guidelines which are enforceable? What could be done to schemes like Ayushman Bharat, to state insurance schemes where hysterectomies are looked at slightly differently so that we rule out and make sure that they come to force only when the public and private partnership. And that is what we are looking now with various state governments to really look at how do we bring in the Preserve the Uterus through a public-private partnership.
Wonderful. Thank you so much, Manojji, for highlighting this. And definitely there is a massive scope of doing that, as you highlighted in the multiple aspects of healthcare delivery and the system in our country. An important contribution from both public and private side can definitely lead to better outcomes, which we all desire for. Before we go to the next round of questions, let me also, kind of involve our audience in that. Many of them, are, coming from medical colleges, and also we have journalists and some, gynecologists, practicing gynecologists also here with us. So if we can get a mic at the, kind of floor, if somebody wants to ask question. If anyone has a question related to it, and or maybe want to, understand that why the scenario of hysterectomy is so in India, where we have highlighted certain figures, certain numbers, kind of, the 3.5 almost percentage of national prevalence, which has much higher in multiple states, and obviously also has a much more lower prevalence in many of the states. Why it happens that way? If there is any question from the audience, you can raise your hand. We can give the mic. All right. So I think no questions as of now. So let's continue with our questions in that case. Dr. Bali, so we understood the lot of socioeconomic factors, the awareness factor about it. You talked about educational background. That if women have gone a certain level of education, the number of hysterectomies have been lesser. Even in this case of if the childbearing has happened, the hysterectomies have been lesser. There are multiple aspects related to this. But at the same time, in many of health schemes, and especially when it comes to government insurances as well, we have seen that high number of such cases happening. Maybe primarily or maybe one because of the insurance cover, the aspect of financial gains become more prominent in that. You talked about the guidelines. There are guidelines, and Dr. Mittal also said that since this is not being only done by gynecologists alone, and there are a lot of other involvements also, it becomes a little difficult to kind of adhere to the guidelines and all that. But at the same time, now seeing in that the similar kind of problems are occurring in government-run schemes. Ayushman Bharat has been a recent example where a higher number of hysterectomies were kind of monitored in certain states, which raised a kind of a red flag. And since a lot of it is a IT driven system, there are a lot of those layers where this compliance can be brought in. How do you see, as a health administrator also, how do you see that what can be an effective policy mechanism, what can be an effective maybe kind of legal framework for around that, which can reduce the number of, we have seen it is happening, when multiple spaces and aspects, multiple laws are being enacted. For that matter, if you see related to ART, IABF, surrogacy, everywhere we have certain laws being put in place, and the purpose is that we ensure the best of the the care for the people, and also at the same time ensure that there is no misuse of any such technology or procedures. How do you see it in the space of kind of really addressing the problem of unnecessary or unqualified or whatever hysterectomies in our country?
The guidelines are there that there should be monitoring committees at the district level, the state level, and the national level. And all these committees will be constituted by officers from the public health system, from the Federation of Obs and Gynae, as well as from the non-governmental organizations. And although this is not a reportable or a reportable kind of a condition, like if you have a cancer, you have to register it, or if you have a communicable disease, you have to register it. But for hysterectomy, there is no government legal order that it has to be reported. But we are collecting the data. Presently, we are collecting from the central government hospitals in Delhi. And this data will be analyzed. And each patient, regarding the age, the parity, the mode of hysterectomy, that is abdominal or vaginal, and the histopathology, every data will be collected and analyzed. But at the same time, as ma'am has pointed out, that since 60% of these surgeries are being done in the private sector, so collection of the entire data becomes an enormous procedure. And what we are planning is that when these hysterectomy committees will be operational, and we might get data which is more correct from the district, states, and then the national level. And ICMR and our directorate, we will be analyzing this data, and then we can come up with more suggestions regarding how to correct the situation.
Thank you. So I think this is a work in progress.
Yes.
You know, from 2013.
The vision is there.
Yeah. So from 2013, we started including in you know, kind of national health and family welfare survey, and also now this has given us certain data, and that is you know, itself is a eye opener of seeing that you know, out of 7 lakh surveyed women, around 22,000 of them you know kind of underwent this surgery. And if you, as you had highlighted, you know, the very interesting in a different age group, the median age is also very, you know, kind of you know, shocking in that way. So it's good that it says, you know, we are moving toward that direction, and I'm sure that as the more data, you know, kind of is pulled in, and we have a more understanding about the prevalence of a problem, we should be, you know, kind of coming up with the right mechanism around it. Dr. Mittal, she also mentioned about, and you also yourself have mentioned about private settings and private hospitals. Since you are a part of that, you know, universe, though not at that level where, you know, actually this kind of activities may be taking place. But as I also mentioned about, you know, one of the case, and which will be just, you know, one example, at a private space, even large hospitals also, as we see, you know, in which is a very, you know, kind of a common sense understanding that you have more cesareans, you know, set in private hospitals, whether it is in a, you know, semi-urban area or whether it is a corporate hospital in a city like Delhi or Mumbai, than in the government, you know, setup. Similarly, hysterectomies have also been seen higher in number in private setup. What are the, you know, reasons behind it? You know, that is that a certain business or financial aspect alone to be blamed to that, or you also feel that women health, no matter which section of the society we are talking about, is in generally ignored, and women come or reach to a situation where, you know, reversal of the conditions or treatment of the condition at with non-surgical or non-radical you know, mechanism is not possible, and that is why we see higher numbers of such cases in all across, especially in the private sector. What are the, you know, the reasons behind that?
Thank you, and a very good question. And as you pointed out, right now I am in corporate, but I have been on the other side of fence for more time. 40 years I spent with government.
So then you can give a better
so I can tell you
comparison.
Both angles.
Yeah.
Before I tell you the perspective and question you have answered, I will cite something. this is an incident which occurred about 25 years ago. One of my seniors, very senior gynecologist who had been my teacher at some time in undergraduation, was in private practice. And she was talking about a patient, and she said, patient came such as thing, Sunita, and then I did her history. So I asked her, I said, Madam, when there are so many alternatives, so many medicines also, others also, why did you do her hysterectomy? You have been teaching us that hysterectomy is not the only answer. You know what her reply was? Sunita, if I had not done it, in the morning, if I tell her no, I will give you medicine. By evening, I will come to know somebody else has done it. And you know, it did happen with me also sometimes that I had seen some relative or some known to person or somebody in AIMS. And you know, in AIMS, the waiting period for surgery was also very long. So otherwise also I told them that maybe you will be better managed with medicines or with some alternative treatment and all. Patients who come, and when I tell them, I said, look, I don't think you are the affording kind. You don't even have the insurance. I'll give you a letter in the name of some doctor in AIMS. You will get the free treatment. Madam, please, we don't want to go. The waiting period is so low. So what you pointed out that more is being done in private because people are getting a prompter treatment. That is one thing. Secondly, as you said, in government, there are 3 tiers of services: primary health services, district services, then of course tertiary care or medical colleges. Even when we look at the medical colleges in this country, many of the medical colleges, we get students from all over who would come, have not even heard of thermal balloon ablation, have never practiced TCRE, don't know how Mirena is inserted. So alternative therapies are available even in a government sector in a very select few. And the same is the situation in private sector. In private sector, in fact, you may get more advanced cases. If I need somebody, I was doing thermal balloon ablation in AIMS. To arrange the balloon was a headache for me. Here, if I want to do it, tomorrow my management will buy it, I can do it. So things are easier. Earlier, as I told you, they thought if we don't do it, somebody else will do it. Nowadays, I don't do many patients who somebody else has advised hysterectomy, and I say, no, this alternative therapy is a much better option for you, and they do opt for it. But one more reason. When I came in private sector, insurance companies would cover only hysterectomies. They would cover only abdominal hysterectomy. Then slowly we got laparoscopic hysterectomy included. The robotic hysterectomy, the advanced form, would not be covered by insurance. Luckily, we have got that included 6 months ago. And all the daycare procedures, they were not including in insurance reimbursement. So patient thought, if I have to pay from my pocket, might as well get the uterus removed.
And get it
of
reimbursed.
course, she could be in a center where there is no other alternative therapy. But now, when you have a center where all the therapies are available and insurance, we have got now insurance reimbursement for thermal, for daycare procedures, for everything. Now, a lot of women are opting for conservative. If you tell them, they don't go elsewhere and get it done. Even if they've been advised, they'll come for a second opinion and say, can we save our uterus? So that kind of awareness has to be created. But as you very rightly pointed out, that in private sector, could monetary be a reason? In private sector also, we have 4-bedded nursing homes, we have smaller setups with no advanced facilities and all, where they have no other alternative. All they can offer is hysterectomy, or they lose the patient. So that may be one consideration that more. And same would hold true for many government sector also, that they will have no other alternative. So I think what we have to do, what we really need to do if we really want to save uterus is we have to percolate the knowledge of alternative methods of treatment across the country. Not only awareness in the women that see these are safer, these are better for you, these are less expensive, and all those other things. Also, at the same time, make the facilities available.
So the accessibility is also.
Facilities have to be made available across even medical colleges. They are not existing.
One more, kind of add-on question to that. You compared the two side of, the healthcare, where one is sometimes is resource deprived, or maybe, the new technologies adaptation or uptake is little slower than what you see in the private space. But at the
private sector, I'm sorry to say, the uptake of new technology is much, much faster than the government sector.
Yeah.
Much faster.
So apart from this, you also have the, the massive burden of patients in your, the government setups, especially, the examples of places like AIIMS, Safdarjung and all that. You mentioned about that it also requires to spend a little bit more time with patient to, kind of, counsel the patient that what is good, what is not good for them, what are the consequences of that, which is sometimes is not, kind of practical in massive, government facilities with, huge, lines out there. Do you see this practice happening in private space? Our doctors, and especially in hospitals like the one you are in, is spending more time with patients? Because that has been a big issue. If in a government sector there is a big queue to take care of, in private space also you have more patients to take care of, because you can then get more OPD charges coming in.
Government sector, the OPD appointment system is still very disorganized. So everybody comes. In fact, AIIMS queue will start at 4 a.m. And then naturally there will be a crowd, and you think you have to see a crowd. You may be seeing the same number of patients, or maybe even lesser number of patients in private. It is more spaced out. There are good waiting areas in private sector. So you do tend to spend time with the woman, counseling her or her husband or family. As she pointed out, you have to counsel everybody. It is there. It is practical. There.
Thank you.
And it can be made practical in government sector also. Well. There is no bar.
I'm sure. The way, a lot of things have been improvised now, especially if you see the passport centers now are fabulously managed. If we take the example of then try to implement in a government hospitals also, it can be a wonderfully done, thing as well. Dr. Rathore, now we will be trying to wrap up, also because the next session, we started late. So, we will eat into a little bit of some of the minutes in the next session, but we'll try to wrap up also. Dr. Mittal also transfer about the new technologies, new, kind of mechanisms, new therapies to the children, kind of students who are going for, practicing in multiple different hospitals. She said that it is not available in many of the medical colleges. You being in a medical college, how, you are seeing this being changed? Are we looking into more such kind of exposures for our students, so that they are going equipped with all possible, up-to-date knowledge about these things, so they do not, kind of take the recourse of something like which is becoming now, out of date.
Yeah, thank you so much. I think it's a very important aspect that we have to look into. Giving right type of exposure during their training. During postgraduate training, we need to focus more on, apart from giving the knowledge, availability of resources, as Madam said, There should be an availability of any progesterone IUCDs, availability of a non-uterus preserving surgeries like an hysteroscopic or a thermal balloon ablation. I think at this point of time, the National Medical Council is revamping most of the medical curricula. Undergraduate, we have switched over to competency-based curriculum, where the sensitization has been coming into it, but we still have a very long way to go. That all these components are they are by and large sort of, and what you say, when we design a curriculum, we have areas which are must know, which are nice to know. So most of these higher, newer technologies which come into picture, the curriculum is not revamped at that particular frequency with which the newer technologies become available. And unless you have a very good evidence to put it into teaching, it sort of become dicey even for people who are making the curriculum. So that is one area where there is a little bit of a mismatch, that the frequency with which we update our curricula, because it's very difficult to disseminate this curricula to the whole country. And while making this curriculum, it's always precaution is taken that what is must know and what is minimum essential. So in that area, I think even DGHS team will agree that we always try to keep it to the minimalistic. Can we give this particular facility to the least equipped center? The smallest medical college, can it be incorporated into the training? So on that particular level, areas, and so they may not be uniformly taught to all postgraduates in the country, all over the country, in different states and different levels of medical college. Secondly, at undergraduate curriculum, I think there is a very important place to put in their undergraduate teaching as an MBBS doctor, the importance of uterine preservation and the holistic role that uterus and genital organs play beyond the reproduction. That's a very simple thing, and probably we will be sensitizing not only the future gynecologists, but future general practitioner, future surgeons who might be involved in care of women at later point of time where there may not be all gynecologists available. So that is something I think which needs to be addressed. And yes, postgraduate curriculum, I think all availability, unless a student learns handling all these technologies in the training, they in a good numbers. Once they go out and start as an independent practitioner, unless they are confident, they won't be able to deliver it. Hysterectomy is some basic operation which most of the MD or MS graduate when leaves the institution is confident about. But whereas if you ask about thermal balloon ablation or an hysteroscopic resection, that cannot be the assured thing.
Thank you so much, Dr. Rathore, and I'm sure the medical education or knowledge kind of moves so fast that it may not be practical to kind of overhaul the curricula all the time, but then plays an important role in a doctor's life is the continuing medical education. How they need to keep training themselves in their profession also, and I think much more than any other profession. Manojji, you and I'm saying you talked about public-private partnership, the kind of capacity building also. CMEs and the role of organizations like yours have a lot of responsibility towards kind of upgrading continuously the knowledge of our medical professionals. How Bayer is already kind of involved in these kind of areas, and what are the upcoming or or what are the things which you feel that need to be done, whether with a partnership with the government, with the partnership with the medical colleges or professional organizations like Foxy, where we can upgrade the knowledge, upgrade the kind of training of our doctors to provide a better solution to patients.
Yes. I think this is one of the most important areas where we focus on. Yeah. Typically, the pharma companies are looked at. We innovate, we do research, and we bring a new product or a solution, yeah, which is a long winding process. It takes 7 to 10 years to get to a new solution. We all know, from identifying a solution or a molecule entity to coming through a phase 3 and getting it approved through regulatory agencies. We invest over 15% of our top line every single year, putting into the R&D so that we have the next solution. I think what Dr. Rathore was mentioning around new technology. Yeah. So we significantly work on that. not only on a new solution, but also upgrading. And some of the gynecologists would know when Mirena was launched was very different because we got a feedback about inserter and then we added Evo inserter in that. Yeah. So in a sense, getting feedback from gynecologists who are using, patients' feedback, we keep on working on to make it better. Yeah. To an extent now, some of you would know that Mirena, which is indicated for 5 years, in some of the markets, we have now data to say that Mirena can be used actually for 7-8 years. Yeah. So all that data sets which is available with the partnership with gynecologists. So I guess that's one part on the technology side, but also in terms of trying to innovate to have a better solution coming in. But the second part, I think, is where our partnership with Foxy and with individual gynecologists come in, where how do we propagate these new technologies, new solutions in a manner which is understood by everyone. And I think we have our role as an innovator company is also there. We do CME programs, where we have doctors. I think that Sunita Mittal has come to our panels a lot of time in terms of advocating what is the right way of using those products. And she mentioned just now something which I think is very important for Preserve the Uterus and where we are actually putting efforts with Foxy is around number of clinicians or gynecologists who are happy and confident as an inserter for Mirena. I think that's one of the challenges which you rightly brought into mind. So we are also looking at in capacity building, not just education on modern management, but also looking at simple things like workshop. Can we have models coming in? Yeah. Can we have digital solutions? We are now looking at bringing digital solutions which can help the community to have a better understanding on insertion. Continuous medical education is absolutely the need in any therapeutic area and in pharmaceutical industry. And I think for gynecology, we are absolutely committed. We reserve a huge amount of investments there so that we are actually partnering with the thought leaders and the key opinion leaders here to really propagate and the scientific way of promoting our products. Yeah.
Thank you so much, Manoj. So let me now wrap it up. And so, India is a diverse country. We see multiple issues when it comes to health of the people, and especially when it comes to the health of the women, which is somehow has always been treated as secondary in our country. We see that in all numbers, in the number of OPD visits, to the access to the care, even in the family decision making, to the availability of care in institution. Hysterectomy might not has been a much bigger an issue for the people who have undergone it, because they haven't understood the consequences of it, which they would have been facing in their life after the surgery. But it is the responsibility of the policy makers, the healthcare providers, the care providers, and each one of those who really feel that we have to ensure the holistic health of everyone, and especially our women, if we really want to build a healthy family, happy family, and healthy society. What we have seen is that there is a very high willingness to address this problem, which has been one of the major cause of concern and an issue of kind of policy debate. As Dr. Bali said, that there is a new data being collected. We are kind of in the process of coming up with new guidelines. Dr. Mittal highlighted that we see a higher exposure, higher training, and more willingness from the care providers also to kind of ensure that women are kind of told and educated about the various alternatives available. Dr. Rathore has highlighted that how the new curricula is including these kind of aspects, and how the continuing medical education is kind of trying to bring in the aspects which can help us reduce or help us provide a very equitable availability and accessibility of these procedures. And above all, what is most important and what all of our panelists have anonymously echoed is that there has to be a much stronger, better awareness about this, that every woman, every family can take the decision, keeping in mind the holistic well-being of the women, which is the, in a way, the foundation and the center of the family and the society and the nation. And with that, we conclude this session, the first session of our Preserve the Uterus National Summit. There will be multiple sessions and some, great experts joining us, the people who are at the helm of the affairs, to let us understand that how this problem can be solved and we can, kind of ensure better health for women and thus for the entire families. Thank you so much for joining all of you on this session. Thank you so much.
And I want to thank organizers for inviting me to participate in this. And of course, want to compliment IHW Council, Bayer and Foxy for taking this very, very important initiative targeted towards women's health. Thank you. Thank you.
A big thank you to all our speakers who have enlightened the audience with the current conditions, set the context for what lies ahead in the day-to-day. And we want to thank Kamal Narayan for steering this discussion so ably. It was such an informative session of the current scenarios of hysterectomies in our country and the major reasons why women seek them and what could be the best solutions available for them given their conditions. We're now going to move on to another panel discussion, and this is on understanding the way forward, state-level policy perspectives on Yeah. Please put your hands together and welcome on stage our next round of panelists. Please welcome Dr. Vairagyam Ramalingam, Chairman, Telangana State Medical Council, who's joining us virtually. We are also being joined virtually by Dr. Hema Divakar, MD, Divakar Specialty Hospital, Co-Chairman and CEO, Artist Vohra. Please welcome Ms. Urvashi Prasad, Director, Development Monitoring and Evaluation Office, Niti Aayog. Please welcome on stage with a loud round of applause, Dr. Rishikesh Pai, President, Foxy, Medical Director, Bloom IVF Group. Please welcome Dr. Rishikesh Pai on stage, who will be participating in this discussion. Please also welcome Dr. Manju Puri, former Director, Professor and Head, Department of Obstetrics and Gynecology, Lady Hardinge Medical College and Associated Hospital. Please welcome Dr. Ritu Sharma, Professor and Head of Gyne, Government Institute of Medical Sciences, Uttar Pradesh. Round of applause for all our speakers coming on stage, please. Please also welcome on stage Dr. Ashish Gavde, MD, Country Medical Director, Bayer. And this session is going to be moderated by Dr. Sudha Prasad, Director, Metitva Advanced IVF and Training Center, Vasant Vihar, New Delhi. Please welcome on stage Dr. Sudha Prasad, who will be steering this discussion. So it's going to be an interesting session where we have leading doctors and few policymakers deliberating on state-level interventions required. I will hand it over to Sudha ma'am to take this discussion forward. Yes, ma'am.
Yeah, good afternoon to all of you. And it's a pleasure to be here. And this session is, I was listening the previous session. So I really congratulate the IHW and Bayer to take this initiative to preserve the uterus. As hysterectomy is already, it's at the high incidence rate. What exactly is happening? Why this is occurring? This is the alarming reason. This is an alarming topic. That hysterectomy, when we are talking about, we are talking only for the Delhi. or we are talking about only the Mumbai? Other than this, the country is so vast. I have been gone to inside the rural areas where people do not know what is the contraception, what is the OCs, what is the pills. Are we talking about that? That they do not know hysterectomy. And when you see that this study of the National Health Authority, it was done in September 18 to April 19, and less than 1 year, 24 lakhs pre-authorization were raised for all package under PM Jan Arogya Yojana. And in this pre-authorization, 21,896, means 0.9% of this were of hysterectomy. This has raised the question that why hysterectomy is so much at the high incidence. What has happened? And this study also has revealed that only the few states are doing so many hysterectomies. This question has been asked, like the Chhattisgarh, Uttar Pradesh, Jharkhand, Gujarat, Maharashtra, Karnataka, and Karnataka has done nearly 75% of all hysterectomy. Why? Are the patient having this only choice of having the hysterectomy, or there is some other reason that they are having more of fibroid uterus or adenomyosis or dysfunctional uterine bleed, which is not corrected by the medical management, conventional management? So what can be the reason? This is the question comes in the mind. But if you take as a total, if you take as a full country, as a India, then we are talking that what is the reason in some states there is more of these organic disorder, or what is the reason behind? So I will ask the first question to Dr. Hema. Dr. Hema
Namaste, Sujaji.
Because I have a very learned panelist in my panel. Dr. Hema Divakar is MD from Divakar Specialty Hospital, co-chairman and CEO, artist for her. So Hema, you are here as on the digital platform. You are on Zoom. So I just wanted to know that how can we ensure capacity building of medical practitioner for non-surgical intervention? Are they knowing that what is non-surgical intervention for the simple heavy menstrual bleed, or some small fibroid, or a small polyp which is hanging inside the uterus? Is it there, or they are just doing hysterectomy as a final state of surgery?
Namaste, Sujaji, and thank you for the kind invitation. On behalf of Dr. Rishikesh Pai, who now heads our parent organization, Foxy, I can vouch for the fact that as an organization, as we being our own watchdogs for what is happening in the country with respect to not only hysterectomies, but also C-sections, women's healthcare in general, we have really strived very hard to build the capacity of our own peer group of OBGYNs. Having said that, it is time for us now to break the silos, because specialists are not available at every nook and corner in the country. And your opening remarks, is it all about Mumbai and Delhi? No, we have to reach the last mile. And the last mile frontline healthcare provider, within their limited capacity, we have to empower them to assess and to refer the cases in a timely manner if hysterectomy is needed, and also sensitize them about n number of options which are available today, including the LNG IUD and including the newer drugs which have come into the market, including the endoscopic procedures, etc., which may not be available in the last mile, but at least they know about it and they refer to the next level. And of course, we can do outreach programs from FOXI as well to reach those areas, to actually transfer the skill and conduct these in a camp setting, that we do the non-surgical treatment, empower them with that knowledge and capacity, and come back. There is only so much we can do in every place, but let's do at least that much, because everything cannot be done everywhere. And entire expertise from the skilled healthcare specialist cannot be totally transferred. So we have to strike a good balance for capacity building. Now the digital platform is available. FOXI has also done on obstetric front a huge initiative called Manyata, where we have transferred the skill entirely through the digital platform. It's working well. So Dr. Pai and others are also toying with the ideas of scaling this up into infertility, into abnormal uterine bleeding, etc., This is one component of the capacity building and sensitization of the entire chain of frontline healthcare providers. So everybody knows and they're singing the same song. The other side, the demand for hysterectomy from the women out there in the rural area, because they're shrouded with a lot of misconceptions. A tiny little 1 centimeter fibroid, they think it'll become cancerous. There is a misnomer about remove the uterus and that is your therapy or the way forward for not having any more children. Many such gross misconceptions which have to be nipped in the bud. For that, we need a huge amount of advocacy to make them also realize what is right for them. With a good mix of this demand and supply, today we may embark on another long journey with support from IHW and Bayer, Save the Uterus, because everybody is talking about saving the tigers, saving electricity, saving water, but we are talking about saving the mothers and saving the uteruses. That's all I would like to say on this platform. Thank you.
Thank you, Hema. You have pointed out very, very rightly that this is for the women health. The FOXI is working for women health, and here we are talking of preserving the uterus. But this question, why this comes, what is the reason behind, what can be done for this? So I just wanted from Urvashi, who is the Director Development Monitoring and Evaluating Office of Niti Aayog. So she's in the government, and what government is doing, government initiative for screening gynecological disease of the entire country. Because I was listening the previous session, and in that session I found that in Delhi we have done this, and we are doing the medical colleges of this data from in the medical college of Delhi or in a city where, no, I am talking of the villages where the maximum population stays there. What are we talking about? We have not seen that part. I have seen that part where the patient is having bleeding, she's having the big fibroid, and she is coming when we go for the camps, and we find out that yes, these are the reason, and they never thought that this can be removed. It's increasing every year. So they do not know if we are going to remove those fibroids, and it is myomectomy is very, very difficult in those patients, then yes, we have to remove the uterus. So what is the government initiative, please, for screening of gynecological disease like fibroid, adenomyosis, and endometrial cancer? In which state, and what is the data behind when the patient comes with a heavy menstrual bleed? Urvashi is on the digital platform.
Yes, I'm here.
Yeah, please.
Yeah. So, so I think, as we are saying quite rightly that, India is not just about what happens in Delhi and Mumbai. We have to look at all the parts of the country, especially the rural and remote parts of the country. And I think, as Dr. Hema put it, that we actually don't have specialists everywhere, and in fact there's a huge shortage of specialists, and there's a sort of disproportionate distribution. And there are some areas we have lots of specialists, but in some areas we just don't have any. So we need to also look at other cadres of health professionals, and we need to train them. We need to build their capacity. We need to use the health and wellness centers that are being set up across the country. And I think that is one big avenue that I would talk about for screening, because if we want to screen, then it's really important that we use these health and wellness centers, which are to be set up at every 5,000 population or so, and we equip all the providers that we have at these health and wellness centers, including the primary healthcare providers, because the focus needs to be very much on primary healthcare. Yes, we need the specialists. Eventually, if there is some problem, if there is some major complication, then of course referral has to happen to a specialist. But in a country like ours, where we have this skewed distribution of specialists and we have a shortage, we need to, we cannot just wait for that ideal scenario. So we need to train these other cadres of health professionals, and we need to also have a public health cadre in place. That is why we are trying to work with various state governments. We as Niti Aayog are trying to work with various state governments to actually put in place a public health cadre, which can not only do basic screening for women, but it can also educate and empower women. So, the other important point that we have spoken about is demand for hysterectomies. There's a lot of misconceptions. Women, even if they have the slightest problem, they think that they need a surgical, invasive intervention. So a public health cadre can create the kind of right awareness amongst women as well, that when do they actually need a surgery, when do they not need one. So I think that is the other very important prong that we are working on. Alongside primary healthcare, also working on a public health cadre. And I think the third piece is on tracking and data, because I am working on, data related lot of initiatives as well. So we need to, as you rightly pointed out in the beginning, that there are a lot of differences between states. Where are hysterectomies more prevalent? Are they more prevalent in the private sector or the public sector? We need to track all this data, so that we can make the right kind of policy decisions, and we can put in place the right kind of policy safeguards, so that, hysterectomies are only happening when they are necessary, and we have a way of tracking this, so that we can pick out, instances where we feel that a lot of unnecessary or additional hysterectomies are happening when there wasn't a strong sort of medical rationale for doing that. So we can only pick that up if we are regularly tracking this, monitoring this, and we have the right kind of data in place. So that is the third point I will make, that we really need to look at data very carefully, and we need to track and monitor this data on a very careful basis, and look at a state wise disaggregation, and then even what is happening at district level. That is when we can make informed policy choices.
Thank you. Very rightly said, we have to track. But at present, I just wanted to have some data, if possible, that how much Niti Aayog has tracked the data and how many states has been covered. That we don't have actually. As a gynecologist, as a FOXY, we don't have that kind of data, that what is the government initiative and how much we have covered. We don't have that. Thank you so much. So we have more than 37,000 gynecologists all over the country. So Dr. Hrishikesh Pai, who is the president FOXY, who is supervising all the gynecologists. So you can imagine that FOXY can make out that what is the significance of screening mechanism before hysterectomy, how many gynecologists or these gynecologists are doing just with the symptom, they are doing hysterectomy, or are they doing the proper screening, and how we can ensure capacity building of health professionals in this regard, and how FOXY can play a significant role in creating a positive impact in this area.
Thank you, madam. Thank you, IHW and Bayer and all of you for calling me here. See, the federation is made up of around 38,000 members spread over 263 societies at present. And one of the things, so there are different aspects to it. So there are three controversies in our federation. One is on saving the uterus. One is saving the ovary also, which is very important. So when you are doing a hysterectomy, many people tend to remove the ovary. So that is very important to save the ovary. And the third is to increase the incidence of vaginal birth. So as far as the government or the general society, they look at us, they look at us suspiciously. Are they doing some gadbad there or something? Are they doing unintentional? So the hysterectomy can be of two types. Unintentionally doing an unindicated step, intentionally doing an unindicated step, and doing an indicated hysterectomy. The point is that the country is developing. Ayushman Bharat has been given access. Obviously, more and more people, needy people who have wanted hysterectomy, indicated one, they are coming forward, obviously, because now they have access. Previously, they used to take the pathology and stay with it in their life. Now, government has given them a vehicle where they can come and get the hysterectomy done. So, I, as a FOXY president, obviously, I assume that all of my 38,000 colleagues of mine are doing indicated work. So if suppose there is a hysterectomy increase, that is good for us. Just like, there is an increase in the cesarean section, which is good for us in areas where there was no access to cesarean, in the peripheral hospitals. So there we need more cesarean, and in the private hospitals in the cities, we need less cesarean. Similarly, as you said, there are a lot of people in the rural areas, they have fibroids, so they are now getting that access because of Ayushman Bharat. So we will have to analyze the data as to whether that the hysterectomies that were done under the Ayushman Bharat scheme, whether they were indicated or not. So that is one part. Now coming to the other part is that there may be certain colleagues of mine who may think that hysterectomy is justified, but maybe people may think that it is not justified. So those have to be, so we need to develop. The problem in obstetrics and gynecology, what I've realized now, yesterday I was sitting on a PPH panel in Mumbai, I was on the advert, is that we are very subjective. Oh, I think that this bleeding was too high, that's why I did the cesarean hysterectomy. We will have to shift from subjective analysis to objective analysis. So I feel that in the future, AI systems will have to be developed in areas that are controversial, so that we can feed that data. Okay, this is the thing, this is the uterine size, this was the bleeding, that, and the computer will tell you yes, whether you want to do a hysterectomy or not. So that some kind of objective analysis. So shifting from subjective to objective. Also in a section, so many new programs have been created in AI for vaginal birth now. VBAC, there are AI programs where you can feed 48 parameters and they'll tell you whether VBAC is possible, means vaginal birth after cesarean section. So similarly, in hysterectomy, because it's a controversial area, we will have to apply some kind of objective yardstick so that it will help our colleagues to say, okay, Baba, the computer said this, I am safe. Because the problem with the gynecologists are, we are on the defensive at present, right? So we'll have to teach them also that, okay, so we need to have an algorithm. So GCPR, one of the things I'm doing this year is 37 GCPRs are being made. All standardization, we are taking all the Green Top guidelines, American ACOG guidelines, we'll make a GCPR. So they follow the GCPR. Everyone follows the same axis, the same algorithm. So if we follow the same algorithm, they can't go wrong in deciding whether hysterectomy should be done or a conservative management like a LNG, IUCD insertion should be done, or a hormonal treatment. So we go, yesterday, superb lecture by one of the professors from Bern about PPH. Beautiful standardized PPH management. Similarly, beautiful standardized GCPR and algorithm for managing bleeding, managing prolapse, managing adenomyosis, managing endometriosis, and managing malignancies. These are the 5 indications of hysterectomy. So once we have the GCPR into place, madam, So and the last thing I would like to say, because I'm talking too much, but awareness building is very important. So the 38,000 gynecologists are there. So Ayush workers, 10 lakh Ayush workers are there teaching them. But I believe, and this is my Foxy mantra, I believe in what is known as integrated teaching. And I want to prove it, and I'm going to prove it on the 28th of this month when I take the yatra from Rishikesh all the way to Calcutta. I'm traveling 3,300 kilometers. I'm covering 20 cities. I'm doing 5,000 patients screening. And I have created a integrated 12-minute cartoon film of womb to wellness, where everything of a woman's life is covered. So when that woman listens to that, because unless you tell her what is available, she cannot go to the doctor and demand for it. If you tell her that this is a goli bhi available hai, she will say, doctor, but why are you telling me hysterectomy? There is goli available. But this information, if you give it more than 12 minutes, I feel they will forget it. Full information, including contraception, everything. I wish I could have brought that. Cartoon film is getting ready. It is in 14 languages. You play that film and she will know everything from beginning of her life till end of the day. It starts with vaccination when the child is born till menopause. That is what I want. So awareness is very important.
Very rightly said. It should be in the regional language. So people should know about it. They should know, they should understand that yes, this goli is also available and now we have to use this, not hysterectomy, not the surgery. I think everybody will be scared of surgery, that bleeding will occur and how I will start working. Because when we talk about the poor women who are working in the farms or who are daily worker and daily wages on their services, so they are really finding that my services will go up if I have to really take rest for 2 weeks. So naturally, if this yes.
Madam, then Dr. of Niti Aayog, madam is there. Please, if I was there, Niti Aayog should earmark 1,000 to 3,000 crores for advertisement and blast the country with knowledge. Not on Sayadri. Of course, Doordarshan is important, but also on colors, also on phone. Any mobile phone which comes now, first the information should come for 2 minutes. Then only they can pick up the mobile. You have to listen to the information, otherwise you can't pick up your mobile. So that is what is needed. Once you give them what is the virus you need, just to put it in their circuit, the virus of information. That little virus can do the difference. It can be a game changer. Give me those 3,000 crores. I will do it. Give me that money.
Very rightly said. I think this should work. This will start now. Now my next question comes to Dr. Manju Puri, who is professor in Lady Hardinge. It is a medical college, general medical college, where the real brunt of the patients are there, who comes from very far off from villages, and they come. Of course, they take time to reach to the final diagnosis. But what is the importance of data and statistic in policy regulation? And do you think that the auditing of private sector is a sustainable solution? Because we have seen that mostly in the private sector, 74% of the patients who reach there in the private sector all have hysterectomy. Which 20 years ago, this was absolutely low in number, but now the number has been increased because either they don't want to take so much of time, or they don't want to take medicine for that. That okay, why I will take, and every visit the private sector is charging, because I have seen the both public sector also and the private sector also. So I can understand how private sector works. So that is difficult for a common woman who is having the whatever the salary is there. She has to take out from those salary some finances to reach up to the private sector, even though they say that, okay, we will take out and final decision has to be made. Finally, I get rid of this uterus. So Manju, what is your point on this?
Thank you, Dr. Sudha, for this invitation, and it's great to be on this panel. So basically, if we think of data collection and data analysis, I think that is central to any kind of public policy, because until unless we have data, we would not know whether our policies, our programs are actually going the right way. Are the interventions effective? So it is, if we monitor something which is objective, which are going to be our outcomes, that is what is going to give us a clue as to whether the interventions should be adopted or they should be adapted. Means, do we need to tweak them? Do we need to change them to be effective, or they need to be abandoned? Because it is not that once a policy is made that we feel that it is sacrosanct and we have to follow it in the same way. So I think it is absolutely essential that we should know what is happening to our outcomes, and we need to balance it against the investment we are doing in collecting those outcomes. So that is part one. But for the data to be useful, it has to be transparent, it has to be accurate, it has to be relevant. There is no point collecting irrelevant data, because that adds on to your burden. So I guess that whenever you are doing any kind of project or forming any kind of policy or a program, it is essential that we do a lot of brainstorming and identify as to what is to be collected. And I think we've already submitted it to the government as to what data is actually required. So we thought we can start with auditing hysterectomies, which are done at an age of less than 40 years. And hysterectomies where ovaries are being removed at the age of less than 40 years, whether a surgeon is doing it or a gynecologist is doing it, because we understand that the surgeons may not have the same sensitivities as the gynecologists as far as the preservation of the uterus and ovaries are concerned. And then, of course, the root and the histopathological picture. So I think that is also what is important. And that is the importance of data and its analysis. Yeah.
So in our new, we are doing starting the yatra and the camp now. So we have that Priyankul is sitting here. So we have made a form for the data collection. We are going to have a consent from the patient so that we can publish the data, and NHFI survey data collection is there. Maybe what madam is saying can also be added. So there are three controversies. So when we are collecting the data, if there is a patient who says hysterectomy, we can do a sub data collection, and whatever the other points she is saying, we can collect them in add to the data. So we are planning. So I am also planning what is known as Badlav Clinic on 18th of every month. I want PMO Pradhan Mantri to accept it one fine day, because PMSMA is free checkup on 9th of every month. When I was Secretary General of Federation, we had launched it with the IMA for antenatal. So 18th of every month is the Badlav Clinic free checkup or non-pregnant women. In that, we are also going to collect the data. So that data collection will be as per the NHFI survey with a consent, and it will be entered into the computers. And I want to cross 7 lakh data, so that I want to beat the NHFI survey, and that data we will analyze and give it to the government, because that will be a very large based spontaneous direct data collection, which will be thorough. In fact, even in our camp this time, we are also doing pap smear or HPV test also. We are doing vitamin D analysis, TSH. We are doing AMH for specific people. So all massive data collection.
Very rightly said, Dr. Rishikesh. The hard copy is very much required, because I know if you send 20 emails, you will get the reply of 2 only. So this is the position in our country. Nobody wants to take the pain. I am going through so many surveys. People keep on sending please fill up 2 minutes only for the survey form, and how many surveys comes. So it depends that we will behind their life that you please fill up this data form. then only you will get the hard copy, and somebody should not keep on just putting the data form just to in the office, okay, we will analyze. It should be time bound and we should come out with some result. So the government initiative also can be taken place. This is very much important. Dr. Manju,
can I
please.
just complete it?
Yeah.
Basically, what I feel is that collection is one aspect, and it is great that Dr. Pai is actually thinking in that line. Analysis, regular analysis also is important. So what we do is we keep collecting it, but we need to look at it, because if you don't correct anything or analyze anything and put it in order, then we are not going to lead anywhere. Another very important thing when we talk about data collection and analysis is concerned, that you find out what are your focus areas, and which would vary from state to state. It is not the same situation across the states. So every state is going to have their own problems. And with this data collection and analysis, the states would know which is their focus area. Then they can put improvement methodology, connect it to that, so that they can make teams, they can have a focused approach, and they can have an effective correction of the problem. So that is as far as the data analysis, collection and analysis is concerned. The second part of the question, that is how sustainable would it be in the private sector? Well, as of now, I feel we do not have any mechanism other than we are happy that we have Ayushman Bharat scheme with us. So that is what will help us collect data from the private sector. Because if you think you are going to get voluntary data from private sector, that is a bit of a problem, because even for maternal mortality, the private sector is supposed to submit the data, but they don't. So I don't think so. We have to have some official ways, like insurance companies, you can collect data from there. Then you have Ayushman Bharat. And of course, you have these surveys, which will tell you that this is what is a problem with this particular state. And then the state can then look at their own policies. The only way you can be sure that the data comes to you is something as stringent as MTP law. So if you equalize it to that, that is the only way. But I think that is not what is required.
Very rightly said, Manju.
Thank you so much.
Yeah. So you have raised the right point, that one is the age, another one is the insurance. So I was going through a paper, the Thomson Reuters Foundation found more than 22,000 women between 15 to 49 years, and out of 700,000 surveyed undergone hysterectomy in Maharashtra. Can you imagine? 22,000 out of 700,000 women had the hysterectomy. Are these women are forced by the family who believe the period comes on their way of work? This is the question. Telangana has also the maximum number of women, those are victimized by the hysterectomy. Women are not informed about the consequences, that what will happen, even though the ovaries are left behind. This ovaries only works for 2 years or 3 years, and then the estrogen level comes down, and so many after effects like heart disease, bone softness, and the backache, and so many consequences comes with this post hysterectomy. So my question is from Dr. Ritu Sharma, that if financial implication are a reason for the women to undergo hysterectomy for the heavy menstrual bleed, how can we address the same? And if your opinion, government insurance scheme have a role to play for increasing in number?
First of all, I would like to thank the organizers, Foxy, President, and ISW and Bear for inviting me to this prestigious summit and sharing the stage with the stalwarts. And thank you, ma'am, for the question. Obviously, HMB is a very important cause leading to hysterectomy. HMB is responsible for more than 50% of the hysterectomies, though in 95% of the cases, we can manage them with conventional means only. But it is always alleged that conservative measures, they amount to more of the annual cost burden as compared to the hysterectomy. But I think this is the thing we need to address at the moment. And for that, we have to change the mindset, first of all, of the doctors as well as the public regarding this. I have gone through a few research papers in the West. They were focused on the on analyzing the cost effectiveness of the initial screening and the conservative measures versus hysterectomy, and they have reported that ultimately the later amounts to more cost burden as compared to the former. That is, the hysterectomy ultimately is more costing more than the conservative means. They have included the operative cost as well as the cost related to managing the consequences after hysterectomy, like the non-communicable diseases, which set up after hysterectomy, like ma'am has mentioned, the heart diseases, osteoporosis, and the also it leads to the decreased productivity at the workplace because of the associated complications like the backache, like the urinary symptoms, and so on. So ultimately, I think keeping in view these research studies, we need to conduct large prospective studies in our setup, in our India also, so that we can come up with the evidence and share the same with the authorities, and also we can disseminate them among the masses for awareness. Then coming to the second point, I think it's high time that we should be now investing on the screening and managing the common gynecological problems apart from pregnancy states in women. So as far as this is concerned, I think we need to strengthen the existing reproductive healthcare programs, and also we need to encourage the government as well as the private insurance companies to cover these reproductive health services as well, apart from the surgical the procedures. So as far as the reproductive health services strengthening is concerned, I think we need to devise the state-specific strategies to improve the menstrual health. We need to enable the women to seek the treatment well in time by promoting the access and as well as the improving the quality of the services provided to them. We need to provide them the medications and also as well as the sanitary napkins in the rural areas free of cost or at a subsidized rate, I think. Then also we need to, I think we need to implement certain interventions to improve the screening part and identifying these disorders at an early time and providing the treatment at an early time for the these reproductive and sexual health problems. Also, I think the policymakers, while they are formulating the national health policy for the women, they should be addressing the consequences of related to the health and the financial implications after hysterectomy. They have to keep that in consideration while formulating these
Ritu,
things.
that the policy makers are making so many policies.
Yeah.
Find out what can be done for these women who are having the, and we should take some help from the Anganwadi also, that who are going home to home, and we should try to find out that exactly in which house what problem is there, and can we do something for them, can we help them, at least some data will be there, and they can be taken, they can be given some transport to reach, because our blocks are absolutely, I'm talking of Delhi, if you go to little interior, nothing is available, no Cuscos and the speculum is available, and we are talking a lot about the healthcare system. So this is very much important that we should equip those areas where the things are there and is simple. If the bleeding is there, simple OCs also can work in many patients. So one should have these kind of things.
Sudhaji, Dr. Sudha,
So I can ask Dr. Ashish that the buyer has taken the very right initiative and right in time when the hysterectomy is absolutely rise in India, and what is the reason behind. But only buyer should not sit and just watch. They should go to unreachable person also. And I just want to know that how can we ensure upskilling and the capacity building of doctors to tackle these issues like heavy menstrual bleed through the non-surgical medical intervention, and how can we empower women over a period of time, creating right kind of ecosystem in these patients with the state government, because you have to be there with the state government and the private hospital. So how can you just through your pharmaceutical agency, how you send your boys to the right area to find out how they can work for this?
Thank you, madam, and good afternoon, everyone. So basically, science for better life is our mission, and Care for Women is really a topic which is close to our heart. And this is really a great opportunity for us to collaborate and partner with several stakeholders, because the issue of women health, what we are talking about, is really a multifactorial kind of a topic. It probably cannot be addressed by a single stakeholder or a single probably body. You know, there are multiple factors, like right from the top Niti Aayog we have heard, then there are state policies, there are bodies like Foxy which we can work. So there are several things that we can do, and we will try to support that. And obviously, as rightly said by Dr. Pai sir, that we will be now looking forward to those GCPRs, which is very important. And as rightly said by Dr. Pai, this is a very important thing which is actually implemented and followed in some of those Western countries. So one is about the preparation of the guidelines, and second is about the implementation part. There, multiple factors can play together here. One of the factors is that, as rightly said by Dr. Pai, we really need to educate those 38,000, 37,000 gynecologists which are closely associated with Foxy. And obviously, it's a huge task. We need to conduct those several of those structured certifications or programs. And obviously, here we need to look at the hybrid format, because face-to-face will not be a feasible option, especially in a country which is having such a wide geography, and the outreach is a big issue. So there we can obviously use these digital platforms to go and have that kind of a thing. Along with that, obviously we also need to look at not only gynec, but because we have heard in the previous session also that so many hysterectomies are not performed by gynecology. So there obviously we need to reach those other fraternities who are also getting into this, and maybe that algorithm what was spoken about, or a kind of a checklist, you know, that if you are able to tick all those things, then you can go for the hysterectomy, or that kind of a guidance can be provided for every person. This probably will take care of the challenges which are associated with unintended, non-indicated hysterectomies, as said by Dr. Pai. Obviously, there still remains a problem of intentional, but non-indicated. Now, that something that we need to look into the reimbursement sector, how we can make it strong, as well as how we can give some kind of a legal weightage, because finally, by definition, GCPRs are good clinical practice recommendations. So these are good clinical practice which are expected to be followed by everyone. How much legal weightage that will carry is always a question, especially in our country. As rightly said in the previous session, there is a huge problem of quacks. Who is going to regulate exactly how the practices are followed or not? So that's another thing that to be looked at it. And the most important part is the awareness or the education of those females, or those empowerment of those women. That probably can be done through these sessions which are conducted right at the time of adolescence. They are happening in many of those metros, especially metros like maybe Mumbai, Delhi, Bangalore, etc. But probably I'm not very sure whether it is happening till the last mile, whether all those female are able to understand, because what we call in medical terminology is abnormal uterine bleeding. It is very important for them to understand what is the definition of abnormal, because many a times, because of the cultural impact, it always gets told to them that it's normal to have that heavy menses, you know. So they really need to understand what is normal, what is abnormal, when to reach out, whom to reach out for this kind of an advice, or the right practitioner they can take. And obviously, while we are doing that, we really need to use local language. I mean, we really cannot use only single language to reach out to all the type of a population. So with use of multiple stakeholders, with the collaboration as well as with use of multiple channels, we will be able to reach out to those. And of course, from the industry perspective, Bayer will be more than happy to partner with all these stakeholders in reaching out to that last mile.
Sudhaji, before I move out, I just wanted to place one point.
And yes, Hema, one-liner point.
Yeah, one-liner. I want to place before you the ground realities in all those women in the last mile where we are planning the conservative treatment. We will need them back and forth. So the access and ready availability of the healthcare should be taken as a comprehensive unit of that kind of a care that we are offering. And also that in an emergency, she will need to get back to us. And thereby the telemedicine or the remote consultations, everything should be well in place when we're going to shift the unindicated hysterectomy bracket into a conservative treatment. That's all I wanted to say. Thank you so much.
Very rightly said. You have pointed out telemedicine. I just wanted my panelists to say about the telemedicine. This is another way of reaching, because I went to a remote village where in a small house on the first floor, one guy was sitting and he was showing the X-ray to some orthopedician who was far off sitting. So telemedicine is another way of reaching to unreachable, Dr. Pai. So we should try to make with government like this. So I will conclude the session and I want the one-liner from all my panelists. Please, Ritu.
I think I would like to finish it with one slogan. I think that would be better for raising the this public awareness. This has been given by one of my students. Uterus नहीं है बेकार, इसी से है नारीत्व साकार, इसके है फायदे अपार, समझ अभी भी वक्त है, समझ जाओ ना यार. Thank you so much.
Thank you. I would like to say that one is that capacity building, algorithm formation is very important. As Hema said, that we have a Manyata program with 16 standards, and we and she have been having discussions of whether how to incorporate 7-8 more standards in it so that it covers the non-pregnant women as well. And, you know, I would like to just, Dr. Khera is also sitting here. Hello, sir. So my brother-in-law is a gynecologist in United States. It's a 3 times or 4 times larger country than India. You know, they get the CT scan in a trailer. His hospital is there, but the trailer comes once in 4 days. It puts and they get the CT scan done. So the whole country now, we should not take the doctor to the last mile. We must use the USA model and bring the patient to the district hospital. We must have the roads till the last mile, because to create infrastructure and sustaining that infrastructure, you do a PHC, after some time it will be deserted. You will not get a person to staff. We have got a lot of staffing at the central level. We need to go there, pick up that person and create mobile units. My dad was the professor of PSM, public health. He got Padma Shri and he started the mobile health clinic when he was the public health professor in GS Medical College. He used to go to the community with the mobile health van. They used to get exams. So the mobile health system has to be created in the country, very robust system, going to the last mile villages, pick them up. You can have mobile scan centers also in the just like the city scan centers. That's where that's where our population is there. That 800 million population is there, and that has to be accessed. That we'll come to know also what are the problems. We are just looking at the tip of the iceberg.
So from my side, I think it is a good beginning. At least we have identified the problem. We have started discussing it. So now is the time when all the stakeholders should come on board and put in their, whatever they can contribute to this program. We know that uterus needs to be preserved. All the hysterectomies are definitely not indicated hysterectomies. The incidence is more than what is required. And we should work towards, advocacy, towards sensitization, towards whatever way we can contribute to this, initiative of preserving the youth.
Very short. One small step can be a giant leap for the women's health, and that's what we all, as a stakeholder, multiple stakeholder, if we take that one small step, that can really create a big difference for women's health.
Very rightly said that the uterus is not meant only for giving birth. It is related to the emotion, the sexual relationship. So we should be always aware when you put the diagnosis that this is there and plan is hysterectomy. So you please, everybody who are in this work, so you have to see, and the Niti Aayog also should. I want one word, madam, from you, that what Niti Aayog can do finally in association with FOXY, who are going to reach to unreachable.
Yeah, so I think, I'll reiterate that we need this public health approach. So we need a public health cadre. We cannot only be doctor dependent given the challenges in our country. So this public health cadre is really the need of the hour for addressing many issues, but also this one, not just for screening of women, but also to educate women, to empower them to make the right choices. So that is one point. And the other point is certainly, on the data which we've been talking about, state, district level, as much as we can disaggregate public, private, so that we can really make the right kinds of policy decisions. So I think those are two big areas where we have also started to do some work from Niti Aayog side, and we'll continue working on that along with the state governments and the other stakeholders. Thank you.
Thank you, Mrs. Urvashi. You have said, and we want the help. We want the association with Niti Aayog definitely, and we will work out with this. Where Dr. Hrishikesh Pai is here, the FOXY president, and definitely we will try to go to reachable who all are there, and they should be pushed towards the interior area of our country where we can do, because this is very much important. From vaginal discharge to the cancer cervix, everybody gets the hysterectomy. So this is very much this is a very unfortunate part of the system that has been there. So one should try to update the knowledge of our doctors, to update the knowledge of our women who are really required the hysterectomy. Thank you very much for giving, and Aswari, you have really pulled me up to here. Thank you so much. And we will conclude the session.
Namaskar. Thank you very much.
Big round of applause for Sudha ma'am for steering this discussion, and for all our speakers who are joining here on the stage as well as virtually. Thank you for joining us and discussing these important issues. I request all of you to please gather for a group photograph. We would also like to congratulate the newly elected FOXY president, Dr. Hrishikesh Pai, for his remarkable journey and contribution in the space of women's health. And we are very delighted to have him with us. And we would like to present him with a small token of our love and appreciation. So I'd like to invite Kamal Narayan, CEO, IHW Council, and Manoj Saxena, Managing Director, Biozydes, to please come on stage and felicitate Dr. Hrishikesh Pai now that he is the newly elected FOXY president. Round of applause for Dr. Hrishikesh Pai. I know we are all very eager for lunch, but we've had such spirited discussions today, and we would like to take this opportunity of having such senior doctors and thought leaders with us to do a pledge so that there is enough awareness about this. I would request all our doctors to please stay on stage. So I would request all our gynecological friends to please come on stage. We want all of you to join us in taking this pledge so that this campaign can be a success and we can save the uterus in its true sense. I request all the doctors in this room to please come on stage to take this pledge. Please to come on stage, don't feel shy. This is a pledge that will really go a long way in making the lives of the women in our country healthier and more satisfying, less troublesome. So request all of you to please come on stage. Right. I would request all of you to please repeat after me this pledge. I pledge to educate and empower women I request you to please repeat after me. I pledge to educate and empower women on heavy menstrual bleeding and extend my support to improve the acceptance and usage of modern methods of management of heavy menstrual bleeding to help women lead a better quality of life. I will stay committed to this cause and take this pledge to preserve the uterus. Thank you all. A big thank you to